we can start. Hello everyone and good morning and welcome to the Tele Trauma Grand Rounds. So today we have Dr. Max Jackson, who is a PGY4 at Florida Atlantic University. And we have him presenting a case of blood bank depletion in a patient with thoracoabdominal gunshot wounds. So over to you, Dr. Jackson, for the presentation.
Thanks so much for the introduction. I just want to say thank you for inviting me to present this interesting case. We had a patient who came into our facility with a high caliber assault rifle gunshot wound to the right lower chest and back. He, on primary survey, his airway was patent. He had diminished breath sounds on the right. He had palpable femoral pulses bilaterally. His GCS was 15 initially. And we fully exposed him and only noted the gunshot wounds in the right lower anterior and posterior chest. We had done a FAST at this time, which showed fluid in the right upper quadrant, and a chest x-ray was obtained, which showed a large right hemothorax. So at this point, we put a chest tube into the patient. He was becoming tachycardic, but was remaining normotensive at this point with systolics in the hundreds. The chest tube, put a lot out onto the floor as well, but we got over 1 liter into the canister, and massive transfusion protocol was initiated at our facility. We also were able to attain central venous as well as arterial line access in this patient and proceeded to the OR from this point. In the OR, we started with a right-sided anterolateral thoracotomy because upon placement on the table, patient was becoming unstable, and we explored the right chest first. There was not a significant bleeding from the lung or anything in the chest, but we did notice a very large diaphragm injury and blood pooling up from the abdomen into the chest. So at this point, we decided to extend our thoracotomy into a thoracoabdominal incision, and we began to explore the abdomen this way. We noticed a large injury, grade 5 injury to segments 6, 7, and 8, as well as blood pooling from behind the liver. And we were concerned about it with the trajectory of the bullet. We were concerned about a retrohepatic cable injury as well. The liver was packed. We packed everything, made sure that we didn't have any other injuries, and then we addressed our bleeding from the liver. And we started by doing non-anatomic wedge resections of segments 6 and 7 to open up the face of the liver and expose the liver better. Before we had done this, we took down the falciform, took down the triangular ligaments to mobilize that right liver better and really show where the damage was. And then when once we had done our resection, we saw the bleeding from the liver, which we started controlling with large, blunt tip needles, as well as packing and like Arista products. And then there was a injury to the retrohepatic cava, which we were able to primarily repair as well to control bleeding from that. At this point, there's concern about onset of coagulopathy. The patient had received 28 units of RBCs, 20 units of FFP, 2 units of cryo, 5 of platelets, and 1 of Kcentra. And we decided to proceed with temporary chest and abdominal closure to proceed to the ICU for further resuscitation, and before coming back to the OR within 12 hours, or once the coagulopathy, once we had reversed the patient's ABG temperature and his coagulopathy on his TEG. So initially, when he proceeded to the ICU, the ABG was acidotic, 715. CO2 was 56.8. It was low PO2. We continued our balanced resuscitation. He got another 10 units of RBCs, 8 FFP, and 3 of platelets in the ICU, as well as some crystalloid products. and his repeat ABG would show an improvement within 7 hours. He was warm again to like 36.8, and his TEG had improved, and we decided to return back to the OR to examine because his chest tube had continued to put out about 1 liter over this 7 hours that he was in the ICU. And there was concern about ongoing bleeding and needing to correct that. Prior to returning, this was our postoperative chest x-ray, which, it shows that he still has blood in the right lower chest. And it, we were attributing that not from bleeding from the chest, but because we hadn't repaired the diaphragm, there was still blood coming up from the liver injury into the chest, and that was what we were attributing it to. So then we took the patient back, and we did a relook thoracotomy and laparotomy. We evacuated hematoma. There was still some bleeding from some small venous bleeding from the liver, and we were able to control this with more suture and repacking the liver, and we had better hemostasis at this point than on our initial operation. We had evacuated probably about 4 liters of blood. Most of that was old, not like ongoing bleeding. But he then proceeded back to the ICU. And during this return to the OR, we actually had run out of our blood products. So at the time that we ran out of blood products, he had received 58 units of RBCs, 41 of FFP, 5 of cryo, and 7 of platelets. We subsequently decided to start transfusing him, adjunctives to, blood products because we were out of what he needed to, the 1-to-1-to-1, which has been shown in one of the big EAST studies, to optimize mortality in these patients who have ultramassive transfusion requirements. And so we're kind of throwing the kitchen sink at them, to, for lack of a better term. So when he came back to the ICU, he was intubated. His gas was 742. He still had a lactate of 14. We started CRRT on him, and as well, his urine output had been downtrending, and we also gave him TXA. We gave him PCC, which is a 4-factor in the US. As well as a fibrinogen complex. Throughout the next 12 hours, his lactate downtrended from 11 down to 7.8. We continued our resuscitation over about 7 hours until we were able to get blood again, at which point we were able to reinitiate transfusing the patient with some blood. The whole entire county of Palm Beach actually had run out of blood for this patient, and so we weren't able to call other hospitals, so we had to go, I think, down to Miami. We're in a hospital, we're about an hour and a half north of Miami, and we're a couple counties up, and so we're waiting to get all the blood from down south in order to continue resuscitating this patient, and we had to use these adjunctives to try and make it work. His LFTs uptrended initially. They stabilized around a little bit over 3,000, and then began to downtrend into the 2,000s and 1,000s over the next several days. We would take him back. The hospital is post-operative day 2. It's really 24 hours after that second operation, and we removed the packing from the chest. At this point, we performed the formalized kind of diaphragm repair and closed the chest and abdomen. Evacuated about 400 cc's of old clot, but at this point there was no active bleeding from the liver or in the chest, and everything appeared hemostatic. Over the next several days, he would have a prolonged postoperative course. He was in the ICU for about a month. He required tracheostomy and PEG placement. he had ended up having his abdominal wound became necrotic, required serial debridement, eventual skin grafting. He was eventually decannulized, transferred out of the ICU, and then finally transferred home and was walking home, breathing on his own in about 4 months post-operatively. And that's our patient. Does anyone have any questions or comments about how you would have approached this guy? I would really love to hear it. It was an interesting case for us.
I think we can ask all of the panelists for their comments, and maybe if they have experienced a similar case. Dr. Hodgman, do you want to go first?
No, great case. I don't have too many comments. You wanted to save this patient who most likely will have died, and you managed to save it. Congratulations.
Thank you.
Dr. Kasim, would you like to make your comments?
This is a case from hell. And I wish none of my colleagues encounter something like this, because I think it's a terrible thing to run out of blood in your county, so you have to scrounge around for blood from other places. So my question was going to be, that I would be asking myself, how would I avoid this? What could I have done from the beginning that I don't have to use up every little drop of blood that I have in my county for one patient? And there lies the dilemma. How do you go about doing that right from get-go and start? What could you have done? So, I mean, I'm glad that you saved the patient's life at the end, that you walked out of your unit and went home. That is commendable. But in doing so, you've exposed yourself to problems that I'm sure that you thought about. What's going to happen if somebody else comes in and you need blood, and other patients. So my question to the panelists is going to be, how do you go about stopping something like this so you don't have to use up all your resources? What can you do right from the beginning, knowing that this patient is bleeding and I need to preserve my my blood bank and the blood product, etc. At the same time, I want to keep him alive. So, could one do something different that you don't use up all your resources from the beginning? Would I be brave enough to just pack the patient and sit tight and see if I can get hemostasis? The other question that I have for the panelists, there is this thought that you need to return to the operating room within X number of hours. I think that is a fallacy. You don't have to go back to the operating room for a second look operation within X number of hours. I think that the right answer to that question is you go back to the operating room when the patient is kind of stable, not because that you're curious what you have done, is it working or not. So there's several questions here, and I'm sure that Dr. Hoffman got away easy, but I would like to probe him a little bit more to see if he can feed us a little more information as well as Dr. Super and Dr. Untra. Thank you.
Dr. Hodgman, would you like to answer Dr. Kasim's question?
No, I will let Dr. Ultra go first.
Okay, Dr. Andrew, you want to go first?
Yeah.
Well, yeah, I think they're all very good questions, and I'm sure that Dr. Jackson and his team have gone over this. But as Dr. Hodgman said, it's a great save. Yeah, it's a great. You saved this man. It's a retroperitoneal cava injury. You saved his life, and that's the time to go over it and say, okay, this is what we did. These are the problems we had. And as Dr. Kasim is saying, how can we do it? What can we do next time based on this? What would we do differently next time based on this experience? And it's certainly better to be saying that in a situation where the patient is, I guess he went home. He's probably going to bring you something for Christmas and is going to walk in or send you a text, thank you for saving my life, whatever. You did a great job. So, but for starters, I have some questions for Dr. Jackson about what happened during the time.
Yeah.
But for starters, what Dr. Kasim said, you don't have to, you took him back after what, 12 hours, 16 hours. Fine. He was not acidotic. He was warm, stable. You took him back. And I might say that, look, we used this much blood, and then talk to the blood bank. Well, how much is left? And maybe we can go ahead and replenish the blood bank, totally fill it back up. So, if we can wait a little longer, if we can wait another 12 hours, we can have a bunch of stuff shipped in from Miami. And the Red Cross would do that. That's what they, the blood bank system, they can certainly do that sort of thing. So that's one possibility. And I think you probably could have done that, but no harm done. I mean, at the end, everything turned out fine. No one else came in the meantime, but that's certainly a consideration. That so I think you probably thought of that, and that was probably doable. But just some questions about the conduct of the operation. So when you went in, you started with a thoracotomy. So I assume the patient was in the left lateral decubitus position, or supine?
No, the supine, because the patient became unstable once we had actually placed them on the table.
Yeah, that's fine. And and Dr. Supa is there, and I'm sure I not to steal his thunder, but I still remember that he presented another case of a retrohepatic cava injury, and he's shaking his head. He remembers that case where really the only reasonable way to deal with it, and in my day we talked about this atriocaval shunt or the Schlock shunt, and everyone talks about it. No one's ever done it, and by the time you get it done, it's too late. But in this case, the thoracoabdominal incision, and you basically planned it that way. So in Dr. Supa's case, I think the patient was also supine. Usually for a trauma patient, you put them supine. And in this case, if the patient could tolerate it, because I would have anticipated in this case a retrohepatic caval injury, if you could have put them in the left lateral decubitus position, immediately do a thoracoabdominal incision, you can very quickly get control of the place where it's bleeding. That's what Dr. Supa found, right? You remember that case, Dr. Supa, right? You presented it here a year ago, right? You remember that. But in this case, the patient supine, you basically did the same thing. The other point, and I didn't know this, but one of our colleagues next door in the military hospital, the Roll 3 military hospital, is a vascular surgeon at I think it's the BAMC, the Brooke Army Medical Center. And what he recommends, instead of the Schrock shunt, the equivalent is VV ECMO, which is basically an active shunt from the femoral, cannulate the femoral vein and the internal jugular vein, and it's you shunt the blood from the femoral vein to the jugular vein, and then you have the suction on the ECMO, which is like the pump sucker on the cardiac bypass machine. You put that in there, and all the blood that's lost goes back into circulation. So you reduce the bleeding, and then you save on blood. And if that's available, that would be something to consider. You had a central line, so you could change that over a guide wire for the upper cannula, and then you put one on the groin, and you're good to go. The other thing you can do if you didn't have that, if that weren't available, is the cell saver. If you have that, where you just suck everything out, you use less blood. And so those are all the things that you could have done ahead of time. But I don't know how long that very first operation was and how much active bleeding you had during that first operation. If you sort of under control, but the operation made him bleed more. I don't know that was the case, but those are the issues to to go over? You know, how could you have reduced the amount of blood that he lost? It sounds like most of the blood that he lost was lost from the injury.
Yeah, there was a significant amount of bleeding during the operation. We Pringled the patient. I don't think we did total hepatic isolation. But unfortunately, you know, my attending who was in this case with us, he did his training up at Shock with Dr. Squee and talked about VV ECMO that they would do in these kinds of cases. Sometimes up there, unfortunately, our facility doesn't have that capability. And to get cell savers, you know, when we did the take back, maybe that would have been a time we can get it, but we don't have people for cell saver readily available in the facility 24/7. So that's part of why that wasn't done in ours. You know, we're about a 300-400, we're like a 400 bed hospital. So some of the things that, you know, you would definitely be helpful in reducing blood loss and utilization of additional blood products. Unfortunately, we don't have those available.
And then, so the only thing I would add based on what you said is that the liver isolation, it would have been easier with the thoracoabdominal incision. So you can get above and below the liver and the IVC, and then the Pringle, and then clamp the aorta. And then that you would have saved, I don't know, maybe 5 or 6, a bunch of units there. But anyway, it's really, considering how it went, beautiful job. And maybe, you know, it's time to tell the folks, okay, you know, you need an ECMO machine in the house, just one. You know, that's now, you know, you can, they sell them at the Apple store, so you can just, you know, everybody can have one.
Exactly.
But Dr. Supa's the expert here. Yeah.
Before I go to Dr. Supa, I'm just going to address the question in the chat from Dr. Kobe. So he's asked whether the liver, the damaged liver was bleeding after the resection, and whether you needed to pack it to stop the bleeding.
Yeah, after when we do the resection, there still was some bleeding, but what it does is it, you know, my attending is Dr. Azar. He's trained up at the Shock school, and they talk about, I think Dr. Squee talks about, you take off one side of the liver so you're only bleeding from one side, and that helps expose that area so you can control the venous bleeding a little bit easier than operating down in the hole. And so, yeah, there still was bleeding, but we felt comfortable when we were closing the initial OR, that we had adequate hemostasis to at least allow us to resuscitate the patient before taking him back again.
Thank you, Dr. Jackson. Okay, now I'm going to go to the expert, like everybody said, Dr. Supa.
I'm not an expert, but in this case, I think Dr. Jackson did a great job saving this patient. It's obviously unsurvivable injury, and you saved the patient, so I'm very impressed. And for my comments to this case, number one, I agree with Dr. Untras to use auto transfusion in this situation. Cell saver may be a way to go when you don't have adequate blood products. And the second thing, I like right thoracoabdominal incision for exposure of the retrolytic IVC injury. And what I usually do is I usually cut the diaphragm from the anterior part down to the vena cava hiatus. By doing that, you will get the even better exposure to the retrolytic IVC. And before I start doing those things, I try to Pringle the liver and pack the liver first. If Pringle and liver packing cannot stop the bleeding, and I see a gush of venous blood from behind the liver, I think about the retrolytic IVC injury, and I do all those maneuvers to expose the injury and repair it. But I think you did a very good job saving this patient. Thank you very much, Dr. Jackson.
Thank you.
Thank you, Dr. Supa. Dr. Hodgman, would you like to add anything?
Sure. Okay. First of all, I also remember that case from Dr. Supa, because I would have never thought about coming with that approach of opening the chest laterally and get the IVC so well exposed like you did. I haven't had the opportunity to do that, but it gives me peace of mind to know that I have that in my armamentarium now. This was one of the beauties of this conference. In this case, as Dr. Untra was mentioning, the liver isolation, complete liver isolation. Yeah, the Pringles maneuver is the easy part. And after that, if you continue to have bleeding, it's obviously something coming from the hepatic veins. You have the chest open. So it's the difficult part is not the infra-hepatic control of IVC. That's easy to get. It's always the suprahepatic, and you have to open the chest, but the chest is already open, so you can quickly isolate the liver in a case like this, and maybe decrease your blood loss. Cell saver, we have it. It takes some time to set up, but in this case, you have the time to set it up. So that's a very good option. I don't know what ECMO your vascular surgeon has there, but I imagine that probably, I know that this is being done for, it used to be done for liver transplant, whatever, but it's usually a cardiac surgery circuit because the ECMO circuits cannot have air in. So with a retrohepatic IVC injury, very quickly you get air in into the circuit. So I imagine that what your vascular surgeon in the military hospital is talking about is a cardiac surgery circuit, because in those cases you can deal with the air when the air gets sucked into the system. In an ECMO circuit, the moment the air gets sucked into the circuit, the ECMO circuit will stop. So probably that's what they were using, and that's what they were being used before for liver transplant, because it's another problem. If you have the chest open and you say, okay, I'm going to do a liver isolation, patient is already hypovolemic, and you cross clamp the IVC, many patients do not tolerate that. Many patients, immediately there, they crash. So in those cases, you use the venous circulation to maintain the perfusion to the heart. But it's, I don't know if the viability of that. And so those are really very, and Dr. Kasim was asking about the viability of blood. I just happen to be, just by chance, I am one of the co-chairs of the ethics committee at Tufts. And I've been involved in medical ethics for many years now. And we always talk about patients' autonomy and non-maleficence and beneficial treatment, whatever. So there are more, but the four basic tenets of modern medical ethics, at least in the United States, is first, respect for patient autonomy. 2 is make sure that the treatment is beneficial. 3 is make sure that the treatment is not harmful. And finally, the 4 that we all tend to forget in the United States, because we seem to have unlimited resources, is called distributed justice. And distributed justice means that you cannot use all the resources for one patient or for a limited number of patients. This is done surprisingly many places in the United States. For example, Oregon has a system like that, where the resources for Medicaid are allocated based on needs. And so the things that will benefit the higher number of patients with the lowest cost are allocated first. For example, vaccination is one of them. Very expensive chemotherapy drugs that have very limited improvement in survival, that will very limited number of patients that are not approved. So they're being done that way. So we apply the principles of distributive justice. Here it was not kept. So trying to save one patient, you might have had, I don't know, a bus crash, a school bus crash just outside your ER, and there are 3 kids with relatively minor injuries that will need blood, and you don't have blood. So that's something that we tend to forget. I've been guilty of this many, many times, more than I remember, but we should be mindful that there is a limited amount of resources, and in this case, everything went well. But as Dr. Kassim pointed out, it might not have ended well, and suddenly you get one or two more patients that or more that you cannot save because there is no blood anywhere. The system of blood distribution in the United States is for the people living outside the United States is a little bit unusual. Very few hospitals have like, for example, we were talking about Argentina initially. Every single hospital processes its own blood. So people go, donate blood, the blood is processed at the blood bank and transfused from there. And sometimes in cases like this, you request blood from different hospitals. In the United States, it's done by the American Red Cross. So recently nationwide was a shortage of platelets. And for example, or sometimes there is shortage of other blood products. So you cannot have a drive if suddenly an area have a shortage of blood. Like for example, it's a major disaster, you can have a blood drive in any single hospital in many places in the rest of the world. In America, that's much more difficult to do, and you depend of the Red Cross doing that distribution. I imagine the other areas might be different, but in the Northeast, recently we have a big shortage of platelets that was creating problems for many elective surgeries like cardiac surgery and things like that. So that's all I have.
Thanks. Yeah, I think that's a really good point too, especially with patients when we have people who have mass casualty incidents and how that changes how we allocate our resources. I totally agree. How we have to approach some of these events.
Dr. Untrek, would you like to add something?
Yes, I meant to ask, after the first operation, before the patient went back for the second procedure, what was his hematocrit?
Hematocrit was around, I think it was around, the first one was around like 7, but then it went up to 10 with our continued transfusion.
The hemoglobin went up to 10. Is that right?
The hemoglobin. Yeah. Sorry. Yeah.
10. It was 7 after the first operation or before the second operation, or
after the first one. After the first one, and when he came out, it was around 7. He was like 6'8", and then it was 10 before he went into the second one.
Yeah, and because you can. And he was in his 20s, so a young, healthy guy. You can,
no, he was 52.
Hemoglobin is 52, but healthy.
Yeah, relatively. I mean, hypertension, depression, things like that.
I would call that a young, healthy guy. You snap your fingers, you're going to be 52 like that. So don't, 52 is young. I mean, I can't remember. It was a long time ago for me, but still, with no heart disease, non-smoke, whatever. With no history of heart disease, even at 52, a hemoglobin of 7 is acceptable. So that's okay. And then at the end, after he came out of that, which operation was it? The third operation. At the very end, after there was no more blood to give him. What was his hemoglobin then?
It was around 8. Yeah. It wasn't
at the very
end.
It wasn't less. So he probably. Yeah, although it was still, he probably needed a good portion of that blood because you couldn't let it get. You shouldn't below 7. You have to start giving blood. So it was 8. Yeah. Well, after everything, it was just 8. It's probably so. It's not like you could have avoided giving him the blood. He needed that blood. And the other thing is, Dr. Hockman can't hear, and he's a very, very good point. But you see. There are people that misunderstand, or for whatever the agenda is, they use the issue of distributive justice as sort of a weapon of aggression against patients, or at least it seems that way. In Uganda, there was an old elderly British anesthetist who had control of the ICU, who would bring all kinds of nice equipment that give them, so they let them stay there to keep control of things. that was very, very nihilistic. And, there was a 10-year-old boy that had pulmonary tuberculosis. He needed TPN. We had a stock of TPN that someone had donated. And, the Ugandan doctors wanted to, the surgeons, the residents wanted to use it for him. And this person said, well, if we use it for him, we won't have it for somebody else, which means that you have resources, but no one ever gets the benefit of them, because if you give it to one, then no one else will. Now that's really a corruption of that ethical point. And in this case, if you just have one patient and the resources available to everyone in the area, if there were more injuries coming in, the paramedics, they would call first and say, okay, well, we have no more, we emptied our blood bank, you should take them to Good Sam, right? You have a bunch of hospitals in Palm Beach County, don't you? That good hospitals that can take care of these things, that can lend you blood. So, in this case, this is the exception that proves the rule, that you have access to resources that in your case, you wouldn't have had to worry. In other cases, I agree. What we would do here is we would call a walking blood bank. We'd call for low titer O negative blood, and then eventually type specific blood from the others. If we needed more units, they get fresh, warm blood, and we could get that as we needed it. And, and again, if we had 30 casualties, which would be almost impossible in our setting, we may have to make those difficult decisions, that you don't want 6 people to die to concentrate on this patient, and then this patient dies also, that we could have had 1 death and not 7, but those are all very, very hard choices. In this case, it worked out okay, but it's a worthwhile, certainly worthwhile raising the issues. And but great case, man. I mean, there are a lot of people that would love to have a case like that. Go ahead and criticize me, but or criticize you, but you say that your patient is not criticizing you; he's thanking you. So,
yeah, it was a very great save. It was a very personal case for me. So very good.
And you're a resident, right? 4th-year resident.
Yeah, I'm a resident. I was a 3rd year at the time. I'm a 4th year now. I'll be applying for trauma fellowship this year.
Well, there you go. So you got that story. So there you go. You go in and you tell them that you're set. Very good. And you should ask them to review the video of this, and when you apply to University of Miami, they'll just offer you the spot.
Will do.
Okay, thank you, Dr. Anshak. Dr. Kasim, would you like to add anything after all of these comments?
Well, a couple of things. I noticed that you gave TXA somewhat late in the game. Am I right?
Yeah, the first was given, let me see. It was given right after the first operation, which was probably about, by the time he got it, I would say it was probably about 5 hours. So it's outside of that 3-hour window that would be ideal to give it.
Right. So you need to correct that for the next patient. Second, the walk-in blood bank, we have it in Oregon, and that needs to be set up before you see a patient coming into the ER with massive casualty who needs massive transfusion. And perhaps Palm Beach Hospital can initiate something like that. But then Palm Beach is high-end society. They may not be so keen on wanting to donate blood for the poor and the injured, but it is worth pursuing to see if you can have something like that available, so you can call upon an emergency situation. And the last thing is that all said and done, you did a great job in saving the patient's life. And of course, thank God that particular week or month or whatever it was, a week of days, you didn't have any other casualty coming in requiring a lot of blood, because then you'd have been in duck soup.
Yeah.
and something to think about.
Yeah, definitely. Yeah, we had a couple other, there were low caliber gunshot wounds and knife wounds that day, car crashes, but nothing that was too serious, and we're fortunate for that. And yeah.
Do you get a lot of injuries like this in Palm Beach County? I thought it
We
was a very affluent society.
We do. There's a lot of gang violence in our, so there's a very affluent area, but there are also a lot of lower income areas. It comes from, historically, the cocaine trade used to come up the Gold Coast. And so a lot of gangs grew out of that, where they would fly in the cocaine to these small airports and then distribute from down here. So they shut down a lot of the cocaine trade, but the gangs have survived. And we still see a lot. We see about 30% penetrating trauma. And we do see a lot of, some high caliber, as well as, regular, pistols and low caliber gunshot wounds.
But if I can just add, this trauma is really in West Palm, not in Palm Beach, not on the barrier island,
yeah,
right?
Not on the island. No, yeah, this is in Riviera
Yeah,
Beach, which is
you
just
can't
north
get
of
into
Palm Beach.
This wasn't in Mar-a-Lago. This didn't happen in the dining room of Mar-a-Lago. No, it didn't, and it wouldn't, or anywhere else in any of the neighbors. And they can't. They have protection. It's like Chicago. It's all there in one place, and the rest, they have adequate policing. But it's too bad, that anyway.
Yeah.
Thank you, Dr. Jackson. Thank you, all of the panelists, for all your valuable comments. I think Dr. Martos is here. Dr. Martos, do you want to make final comments?
Yes, I would like to say thank you very much for Max Jackson for the presentation, Larry Lottenberg for being presenting this in this meeting. You had this meeting for 12 years. Right now, we reach more than 430 conference. As per I know, is the longest standing education conference in trauma, and I'm so happy to see Cassim on track, Supa here for year after year after year, and it's just a pleasure to have you guys here. And again, to see Horacio, very happy today here as well. Special day for him and for Argentina. But again, I think this meeting shows the power of collaboration, the power of trauma, of academic education, and this is very important. Through this meeting, we know each other. I saw some trauma residents from Miami going getting a job, getting accepted for any other place. Like I know there's some people from Miami that are in Boston. For here today, Maya is applying for residency, and I know she's applying someplace that have people here as well, and Patricia is applying for residency as well. So I know that at the end, it's a good opportunity for exchange information, and also a good opportunity to know each other, a good place for young talent students and residents and fellows to show their skills. It's a great source of friendship, global friendship. Thank you very much, everybody, for being here. This is going to be the last meeting of the year, and I'm going to come back next year in the second week of January, back with strong case. And please stay connected. It was just a pleasure to have all you guys connecting through this year and throughout the last 12 years. Thank you.
Antonio, Boston is becoming a metastasis of Miami. Exactly half of my staff are former Miami fellows.
Good. How can they move from the sunny state to the winter? I don't know, right? They should be adapted to the snow. But again, thank you, Horacio, for having our fellows
I
there.
see that I was going to say they're trying to post distance from Mar-a-Lago, but I will be too political.
Totally correct. But listen, thank you again. Thank you very much for having our fellows. Again, that's all about education, right? You know people, you met people, and create relationships, and the ones that do right, they have opportunities everywhere. That's what I talk every time I have people want to be a mentee, right? I say, listen, do hard work, be honest, study, and the opportunities are gonna come. That's the way to go. And thank you everybody to having this network be a tool to help so many people. Okay, thank you. Happy holidays to everybody. See you guys.
Happy holidays.
Thank you. Bye bye.
Thank you.
Bye. Happy holidays, everyone. Dr. Untrak, he's gone. Okay. I will email him. Thank you, Dr. Jackson. It was a pleasure having you present. If you
Thank
have
you.
any more cases, please feel free to reach out to me and we can schedule it. Of
Definitely. Thank you so much.
course. Have a great holiday season.